Um, okay, so we're going to start with chapter 48. This will be on your test next week, along with the 3 chapters that we did last week. All right, so we're going to get right into it. These are going to be immunosuppressants. Immunosuppressants are medications that suppress the immune system. Obviously, that's in the name. So I'm going to go over some basic immune system properties just in case, so you know it the way I want you to know it. So basically, this is going to be my whiteboard today. Okay, I have prepared some stuff on it. Okay. So when I have my own cell, this cell would be a representation of all the cells that are in my body, all right, that are mine. Those would be my eyes, my tissue, my brain, anything that is a my cell that my body made. All right. They all have a individual marker, all right, which is like a fingerprint on your cell that says this is mine. Okay. It is called a human leukocyte antigen. All right. So by it being called the human leukocyte antigen, what that means, or you can call it HLA for short, it's the human's version or the cell's version of the fingerprint on that cell. Okay. It marks it as yours. So what happens? Pathogens also have their own antigens or their own identifying markers. You can kind of think of them as like every cell has their ID card on them. Okay. All of your cells have the exact same ID card. It would be your driver's license, right? Because they're my cells. Okay. Otherwise, all other pathogens, things that are in your body that are not yours that we don't want in there, all right, have a different fingerprint. Okay. They carry a different license card. And we have white blood cells patrolling the body to look for that particular ID card. So they're like, hey, are you mine or are you not mine? All right. And if it is deemed that it's not mine, all right, then I'm supposed to attack it. Okay. That's how my body knows what's my cell and what's not my cell. All right. Does anybody have any questions about that? No. Okay. When the body is able to know what is mine and what is not mine, that is called self tolerance. Okay. That basically is just a definition saying my body can say, yes, this is mine, or it can say, no, this is, like I said, a foreign body. Okay. When it cannot do that, it's called non self tolerance. The body can't do it. Okay. That's when my body starts to say, okay, maybe my skin cells, they're saying, oh, maybe for some reason the immune system has a flaw in it. Okay. So then it starts to recognize my skin cells as not being mine, even though they are, because something's wrong with the immune system. And then the immune system starts to think the skin cells are an invader, they're foreign, and it starts to attack my own body. Okay. So when I have that happen, that is where I get my autoimmune. Again, we don't know what is causing the body, the immune system to have a defect in it, where it can't notice some of my cells as my own. That's why we can't really cure autoimmune diseases. All right. But again, my body will attack my own cells because it thinks that they are foreign. For some reason, I can't identify my own ID card on my cells. Okay. Does anybody have any questions about what makes an autoimmune disease? You questions, concerns? Everybody's with me so far? Okay. Yes.
Can you hear me? I'm here.
Yes.
Can you put that screen back up? I was just writing it down.
Yep.
Thank
Let
you.
me slightly. But does anybody have any questions about this grouping of information? No.
No.
Okay. Okay. Great. So we're gonna move on. Okay. So I just want to basically define that's what an autoimmune disease is. Okay. Because that's what we're going to be treating with immunosuppressants, basically. Okay. And then I want to hone in on this part right here. All right, my innate versus my adaptive. So this is going to be another section. My immune system is broken up into two different parts. Okay. Um, the first part is going to be my innate immunity, which is going to be my immediate immunity. Okay. It's going to hit as soon as I detect something foreign. Okay. So basically, this is all in chapter 48. I'm just doing my own little rendition here. These are the first couple of review slides. Okay. Um,
Can you zoom in on it?
yes.
Thank you.
Yep. Um, so I just summarized it here, but it is all in the slides. So if you didn't get something, I'm recording this too. Okay. Um, so like I said, the innate immunity. Okay, that is going to be my first immunity. This is like the soldiers right out of the gate that come and, I see something foreign. This is something foreign for real, right? It says, hey, this isn't mine. Okay. It doesn't have my ID card on me. So I'm going to, mark it as foreign. And then it's going to release histamines and prostaglandins. Those are the two chemicals that start the immunitary response when we have something foreign. All right. So body's like, hey, you shouldn't be here. I'm going to release these chemicals. These chemicals will then start my immune response. Okay. Again, those are going to be my histamines. Those are going to be the main ones. Then we also sometimes have prostaglandins. Okay. When those get released, all right, we start my inflammatory response. My inflammatory response. All right. So when I have my inflammatory response, you're going to get this typical symptoms, the redness, the pain, the swelling, all right, the heat. And then you're also going to get all these white blood cells, red blood cells, and platelets coming to wherever that foreign body is. Okay. So let's say it's a skin infection. They're all going to come to my skin. Okay. Because that's where they need to fight their little microscopic war. Okay. The white blood cells are going to, destroy, eat, discard the foreign bodies. All right, my platelets are going to help clot anything that may be bleeding or need repair. Okay. So those are what those come there for. Okay. And then my white blood cells can also release a chemical called cytokines. This is important because you'll see it either this week or next week in the medications that we're doing. A cytokine is a chemical messenger. It's a hormone that gets released from my white blood cells. And it goes and runs to the bone marrow and it says, hey, you need to make more white blood cells. Because just like in a war, when soldiers are getting tired, a lot of them have died. Sometimes they need like a messenger to go run back to the camp and ask for reinforcements. Okay. So the cytokines are the messengers that run back to the camp, which is the bone marrow, saying, hey, I need you to make and release new white blood cells so they can come help, the ones that are already there. Okay. Does that make sense what a cytokine is? Does anybody have any questions about that?
So the cytokine communicates with the bone marrow to make more bone cells,
White blood cells, yep. So that they can be
white blood
released and then
cells.
go fight. Yep.
Okay.
Yep. That's it. Okay. So this is going to be the innate side. This is my first response. Okay, now my second response is going to be my adaptive. Okay, this is kind of working in the background. It's delayed while all of this is going on. This is kind of getting ready to attack next. Okay, so this is going to be my antibodies. Okay, so my goal here is to make antibodies. Antibodies are responsible. We want my antibodies to help with the innate. So ideally, they would help on the tail end of when the innate is kind of finishing up, and then the antibodies would come in and kind of help at the tail end of it. Okay. And then we also have my T cells, my helper and my cytotoxic, which come to the site as well. These ones are delayed because they have to get made for that specific pathogen. Okay. That specific pathogen. All right. They can't just go and attack any pathogen. Okay. So once the pathogen is detected, then they have to go and be made. Okay. The T cells and the antibodies have to be made for this specific antigen. Whereas over here on the innate side, this can attack basically whatever it wants to. Okay, any pathogen, it's ready to go. This is like right out the gate. This one takes a minute to get ready for that specific pathogen. We have to have time to make it. All right, so that's why this one comes in at the end. Okay, does that make sense? Usually innate. Any questions?
So for the adaptive to be initiated, the innate has to respond first for it to even come into play, right?
You are correct. It will always work in this sequence, 1 and 2. Okay. Yep. And then ideally, when we have in a vaccine, all right, a vaccine, this, we already make the antibodies, right? That's the whole point of getting a vaccine. We give you like let's say a flu vaccine, we give you a dead version of the virus that basically, it can't make me sick because it's dead or deactivated, right? However, my body's going to be exposed to it, and then I'm going to make antibodies to it so that next time when I get exposed to the flu, then my body already has antibodies so that this side does not take as long. Does that make sense? Why I get a vaccine?
So
Because
you get a vaccine so that the adaptive side don't take too long to kick in?
correct. Because when
Okay.
these two can
Because it's
work
working
together,
in the background, right?
yes, exactly. Because while this is waiting to be made, it's kind of like it has the recipe, right? It has the pathogen, the cook's making it in the kitchen, and then people are already eating the first meal, right?
Mhm.
But how much better would it be if they could eat the whole meal together instead of having to wait in two sections, right? They could have all the food at once, right? It's a big, powerful boom of appetite, right? Goodness. Okay. So it's the same thing, right? My immune system would be twice as strong if it could have both of these working together versus having the adaptive come in at the last minute because
Okay.
it's already been made. Okay.
Okay.
Does that make sense why we need vaccines? Do we have questions about this? Okay. Because that's going to be important when we get to chapter 49. Okay. And then this over here, has anybody heard of graft versus host disease?
I have.
No.
No. No one knows what it is?
Is it basically like when you have like a skin graft and the host rejects it and attacks it? I'm just guessing based off the name.
Yes. However, it can be with the skin graft, but when it happens more in the context that I'm talking about, it's going to be a bone marrow graft. So someone's going to donate a bone marrow or a piece of their bone marrow to a leukemia patient or a patient with bone marrow cancer, like lymphoma, leukemia. Okay. When they donate that, basically the patient's bone marrow is being not effective because of the cancer, right? The cancer is making the bone marrow kind of act all funny. The patient's immune system is affected, right? So the best way to fix this is to be like, hey, let's give you a whole new immune system, okay? That'll actually work, all right? So what they do, since all of my white blood cells from my immune system come from my bone marrow anyways, I'm actually going to give you bone marrow from a donor. All right. It can be family, just like an organ. Someone can, donate it anonymously. Okay. So before the patient can go into this transplant process, they have to get a lot more chemo to basically kill their immune system. So they're starting off with no immune system. Okay. So then we transplant the donor's bone marrow into the body of the patient. Is everybody with me so far? Questions so far? Okay. Then the donor's bone marrow is supposed to make a whole new immune system for that patient, right? That's why I am replacing it, right? Their immune system wasn't working because they had cancer in it. Okay, so I killed what's remaining of their immune system, and then I make a whole new immune system
If you
with
get
the.
on there, she'll slow down.
I'm sorry.
No, I was talking to the lady in the classroom. You going a little
Okay.
too fast, Miss Hyde.
Okay. So with the graft versus host disease, all right, let me kind of slow back down. The patient has leukemia or they have lymphoma. Okay. What that is that is cancer of my blood, basically. Cancer of my white blood cells, red blood cells, and platelets. Okay. The bone marrow is not functioning like it should. Okay. When the bone marrow doesn't function like it should, what is that going to do to my immune system? Basically, I'm not going to have a functioning one. Okay. When I don't have a functioning immune system, my patient can't survive. All right. Even with the cancer, if the cancer doesn't kill them, not having an immune system will. All right. Um, so they need a whole new immune system. So I need to get that from somebody else. And since the bone marrow is the part of the body that makes my immune system, that's the part that I'm going to transplant or donate. Okay. So instead of getting like a organ, they're getting a piece of someone's bone marrow transplanted, which will then help with their immune system. Does this make sense so far?
Could it start making those blood cells again?
Yeah. So the whatever's left of my patient's immune system, the bad one, right? I have to kill it all. I have to kill everything that's left in there, right? So they're going to get loads of chemo to bring their immune system basically down to zero. Okay. Then we take the donor's bone marrow and do the transfer, right? We implant it. Okay. What that's going to do is then it's going to take the patient's bone marrow back up, right? It's slowly going to build back up a healthy immune system so that my patient doesn't die from having no immune system. All right. So basically, we took the crappy one, killed what was left, and then gave him a whole new one. Does that make sense?
So like going bankrupt.
Kind of. And then you steal a bank. Okay.
Yeah.
You steal
I
like
got a
millions.
question.
Okay. Any questions so far?
I got a question. Can you hear
Yes.
me? Okay, so when you bone marrow is in the bone, correct?
It is. Yes.
So when they do the bone transplant, is they taking like a piece of another person bone and putting it in their body to start
You are
the
correct.
okay.
Yep. That is exactly what
So
they're doing.
what part of the bone do they typically use for that?
The very inside, the very, very inside part. That is your bone marrow.
No,
Uh,
I'm saying like what part of my bone? Like will it be the humerus, the tibia, femur?
um, that I think that's a good question. It has to be from a big bone, so I would assume probably like the femur or maybe like a spinal bone.
Okay, and how long do it typically take for their immune to start building after the process?
I'm not sure exactly how long until it becomes full again, but it should start relatively quickly.
Okay.
Yeah. So basically, they're going to be given a whole new immune system. Um, However, the bad thing about that is the immune system that is new, the one that we're regrowing, is that going to have my patient's ID card on it?
No.
Yes,
Are those new white blood cells going to have my patient's ID card, or are they going to have the donors?
the donors.
The donors. So then now I have a bunch of white blood cells that have a different identification card, right? In a body full of someone else's identification card. Do we see a problem with this?
Yes.
Yes.
Yeah, because they're supposed to match, right? My white blood cells should have the same ID card as my body so that my white blood cells don't attack my body, right? So here, all right, then the donor's new immune system in my patient is going to start attacking anything that it wants to in the patient's body. Kind of like lupus. It'll just attack whatever it wants whenever it wants. Okay? Because it's like all of this is foreign. All of the whole body that I'm in is a pathogen. I'm going to kill whatever I want. All right? That is essentially graft versus host disease. And a lot of cancer patients that get bone marrow transplants end up having this. Okay. So not only do they have to deal with the cancer, they have to deal with this version of lupus or transplant rejection. Okay.
Is it more effective than non-effective? Because why even, I guess, bother doing it if it has such a potential of just attacking the whole body?
To put it into a personal perspective, when I was 5, my dad got lymphoma. He was getting very sick. It's basically a last ditch effort. The chemo wasn't working, surgery wasn't working, so they did a bone marrow transplant, trying to get rid of the bad, immune cells and put good ones in, right? He went into remission. So the transplant worked, but he got graft versus host disease.
Okay.
So, double-edged sword. So
Right. Okay.
we did put him in remission. So risk versus benefits, I guess. So questions about this?
So the new things in the bone marrow don't recognize the the body is in, so it's going to go attack whatever
Correct.
it can.
Yeah. The new white blood cells came from the other person, right?
Mm-hmm.
So they're going to think that they should be back in that body. However, now they're in a new body that doesn't read the same. They have different identification markers.
Mm-hmm.
So it's going to be like, I don't know, enemy soldiers walking into a country and saying, whoa, this isn't where I belong. I'm going to start killing all the people.
Got you.
Okay.
Mm-hmm.
All right. So that's graft versus host. How do I treat this? With an immunosuppressant. I want to suppress that new immune system I got. Okay. Because if the immune system's not as strong, can it attack the body as much? No. And then it won't do as much harm. Okay. Same thing over here when we have an autoimmune disease. I take an immunosuppressant to tame down my immune system so there's not as much immune system to attack my own cells. Okay. Do we understand this? Okay. It's the same thing when I get an organ. Like, let's say someone gave me a kidney. All right. That kidney is going to have different markers on it. It's going to have a different identification card than the body it's being placed into. So my white blood cells may go to that kidney and be like, wait, you're not mine. And I'm going to start attacking it. That's how you get organ rejection. Okay. Do we understand? Does this make sense? All of this goodness right here?
Yeah.
Okay. So this is kind of just a review about why I'm taking immunosuppressants. Okay. How they're actually helping my body. All right. With these disorders. Okay. Am I good to move on?
Yes.
Okay. So when we go back, so I just basically covered all of these lovely slides right here. Okay. We go with that. So you should be on slide 13. Okay. Because now we're going to talk about immunosuppressant medications. Okay. So my immunosuppressant medications are medications that are going to take down my immune system. All right. They're going to, my I'm strong. It's doing things I don't want it to do. So I'm going to take it down a few pegs. Okay. So that I can't attack as much. And what are we using it for? My indications, they're literally going to be organ rejection. Graft versus host disease would be an example of that, or autoimmune diseases. Okay. Does everybody understand why I'm taking an immunosuppressant for these issues? No one has a question about that.
So you taking the immunosuppressant for that new bone marrow, right?
That could be one reason, yes.
Okay, because you don't. Hold on.
You taking it because all those is autoimmune diseases, right?
Correct. Or they're going to be some type of organ rejection or some kind of transplant rejection.
Oh,
Okay. Sound good? Okay. Because in all of this, the immune system is overreacting in a bad way, right? So I want to decrease it so that I can't do that as much. Because, like I said, we don't really know why the immune system does that. So we can't target treatment that way, but at least we can take it down a notch. Okay. Kind of give this patient some symptom relief. Okay. So that's what you're going to see here: rheumatoid arthritis, lupus, Crohn's disease, MS, right? All of my autoimmune diseases. All right. And we're going to talk about some of these drugs right here. Okay. So the indication we just said: organ rejection, transplant rejection, or autoimmune. Okay. My mechanism of action, how are they working actually? How are they doing this? All right. Is they simply just make it so that my bone marrow does not make as many white blood cells. Simple enough. Because if I don't make as many, I'm not going to have as many, right, to do damage. Questions about that?
Yeah, can you repeat that?
Yep. So the mechanism of action for immunosuppressants is they're going to suppress the white blood cells, okay, by decreasing the amount that are made, okay, because the white blood cells are doing the damage here. They're acting in ways that they shouldn't. Again, we don't know why, but the way that they're acting is causing damage in the body, right? So if I don't make as many white blood cells, do I have as many white blood cells to do the damage?
No.
No,
Okay.
because your
So
white blood
that's
cells are going to fight for you, right?
yeah, there.
So they
So I
gonna
do
do
need an
that.
immune system. Yeah. However, in this case, the immune system went rogue. The immune system has a defect in it. It's not working the way that it should. So I still want an immune system. I just want to take it down a peg so that the bad part that's not working correctly isn't as strong. Does that make sense?
Yes.
Okay. However, that gives me a bad side as now I don't have as much immunity. Okay. So we put them into a pharmacology-induced state of immunosuppression, okay, which means we're giving you drugs to make you immunosuppressant, okay? Allergies are always a contraindication, so those are on there like always. And then it depends on the patient's condition for the contraindications. However, they probably shouldn't take this if they have kidney or liver issues, okay, because the kidney and liver, you're going to see this with the adverse effects. They shouldn't take it if they have hypertension. And they shouldn't take it if they are getting current radiation therapy. Okay. Like you would want to wait till your radiation therapy was done and then you can take the immunosuppressants. You can take them together, but it's just not the effectiveness of the immunosuppressant isn't the best. Okay. All right. So, what is happening with my interactions here? Okay. Is that many of these immunosuppressant drugs cause toxicity. Okay. So, what do I mean by toxicity? Is that each one of them will cause like liver failure, lung failure, uh, issues in my brain. They'll like attack other organs. So you don't need to know which ones do which. Just know that immunosuppressants in general can cause damage to my organs because they're a little harsh on the body. Simple enough? Okay. And then I'm just going to give you some specific drug ones right here. Tractolimus can cause kidney failure, okay, if you take it with certain antibiotics. So basically, the medication Tractolimus, don't take it with antibiotics, period. Okay. Or you may get kidney failure. Okay. Why? Because antibiotics are also usually pretty hard on the kidneys. So I don't want to take two things at the same time that may, be hard on my kidneys because it'll do too much damage. Okay. Questions there? Okay. This other one, I'm not going to pretend like I know how you say that. Azithromycin, something like that. Azithromycin. All right. This one can cause bone marrow depression. All right. So it will decrease my bone marrow's ability to produce red blood cells, white blood cells, and platelets. Okay. If I mix it with allopurinol, which is for gout. Okay. If I mix it with an ACE inhibitors like lisinopril. Okay. Or if I mix it with any of these, which are also immunosuppressants. Okay. Questions about that? Okay. And then if I also mix the same one with warfarin, it will cause blood clots. So basically it'll make the warfarin less effective. Okay. So I just want you to know these three examples and then just know that in general, all immunosuppressants can cause some such sort of toxicity. Okay. All right. So what bad things can they do? Look at right here. Here are two examples of huge toxicity. Nephro and hepatotoxicity. So that is kidney and liver damage. Okay. I'm not saying it's going to put you into CKD or cirrhosis. However, if you let it go on long enough, it can. Okay. So that's why, like I said, the toxicities up here, yeah, they will cause some type of toxicity. Okay. So basically, I have a risk of liver or kidney damage, which is why you saw those as a contraindication. Okay. Because if I already have kidney damage, do you want to maybe take a drug that may make it worse? Pros versus cons. Okay. And then it can cause low white blood cells, which is basically the point, right? This is why we're taking it. But like I said, the downside of reducing your immune system is that you're also reducing its ability to fight infections. Okay. So we're reducing the immune system that can cause me damage, but we're also, because of that, are more prone to infections. Okay. Does everybody understand that part? Okay. It can also cause anemia and thrombocytopenia, so low red blood cells and low platelets. Okay. Having low platelets makes me at risk for bleeding. Okay, so I should have my patient on bleeding precautions. And I should have my patient potentially on neutropenic precautions, depending on how low those white blood cells get. Okay, which means I'm protecting that patient from me. Okay, I have germs, they have no immune system. I need to wear PPE so that they don't get my germs. Okay, so if you have a
How
patient,
low? How low
yes.
until it's a neutropenic precaution?
I don't know the exact white blood cell number, but I think you would have to get down to like maybe like 2,000 or 2.2 or 2.0, depending on which measurement you're using.
Okay.
Yeah,
Thank
I
you.
would have to get, yeah, okay. Probably around 2 or 3. Okay. And then you can also get a fever, okay, because my body's having to work extra hard. And then hypertension, which is why this was a contraindication, okay. Rash, or just, again, increased risk of infection, but that goes with the low white blood cells. Okay. Any questions here? Okay. So I'm going to give you a few specific drugs, and I'm going to want you to know a few things about each one. Okay. So that first one is that one that we saw a lot with the interactions, that azathioprazine. I'm sorry, I cannot pronounce these names, or my Imuran. All right. You should be familiar with both names. All right. I'm not sure which one I'm going to test you on. Okay. They both all have the same usage, so we don't really have to be concerned with this. You can actually just cross this right off of your notes if you want. Okay. But I do want you to pay attention to the black box warning. Okay. Everybody knows what the black box warning is, correct? No one doesn't know what that is, because if you don't know, ask me and I'll tell you.
Is it like toxic or something like
It,
pregnancy or something like that?
it kind of around those lines. Basically, it's a reason that you would think that they shouldn't be allowed to make the drug. It's going to be like your worst adverse effect. But technically, they can still give you the medication as long as they inform you about it. So it'd be like antidepressants causing suicidal ideations. Probably one of its worst adverse effects, but as long as they tell you, they can give it to you. All right. So it's basically something very bad that the medication can do. All right. Um, so the big thing that this one can do is cause severe, severe, severe bone marrow depression, where it's going to severely lower your immune system and also deplete you of red blood cells and platelets. Okay. That is very dangerous because, again, I need red blood cells to oxygenate my body. Won't really have that going on. I need platelets to clot. I would have a higher risk for bleeding, and then I could be in neutropenic zone. Does that make sense? Okay. Also, I have a higher risk of developing lymphoma or other types of cancer. Okay. So this medication actually increases your risk of getting cancer. Okay. So just that would be a black box warning. So about this one right here, just know both names and then just know the black box warning. Okay.
Do you know how it increases your risk of getting cancer?
Because it's dealing with your immune system and with your bone marrow, it has a higher risk of causing a mutation. Okay, because it's dealing with the creation of new cells, especially your white blood cells and things like that, which would be lymphoma. So it has a higher risk of, a error happening because it's messing with it. Does that make sense? Okay, perfect. The next one, I need you to know both names, but you're going to see a lot of these drugs end in MAB. Okay, so just kind of an ending you can look for. All right. I'm just going to call it Simulect because I can say it. I'm not going to try to pronounce this one. All right. This is a monoclonal antibody. Have we heard of those? They gave that as a treatment during COVID. Does anybody know what a monoclonal antibody is?
I
Okay, so a monoclonal antibody basically means I'm taking white blood cells from one person, or basically not white blood cells, I'm taking antibodies from one person and giving them to someone else. So, like when someone had COVID, right? Someone that already had it made antibodies to it, right? So I'm taking that person's antibodies and injecting them into someone that currently has COVID so that they can get antibodies faster and we won't have to wait for that delayed response for my own body to make them. Okay. So it's kind of like a vaccine, but we're going about it a different way. Okay. So this is a version of monoclonal antibodies. Okay. I'm basically taking some type of antibody protein and injecting it into my patient. Okay. That's going to affect their white blood cell count. Okay. That's all you need to know. We're not going deeper than that. Okay. But it's used for the same reason, so we don't need to worry about this. Okay. The black box warning is for opportunistic infections. Does anybody know what an opportunistic infection is?
Your immune system is compromised, so the infection basically takes its opportunity and takes.
Correct. Yep. There's that one. And then there's also, it can also give my normal flora an opportunity to overpopulate and cause an infection. All right. Sound good? Okay. So that is going to be its black box warning. Okay. And then one other thing that this one can do, all right, is that it can cause cytokine release syndrome. Okay. And that's where that cytokine word comes back into place. That's why we went over it earlier. Does everybody remember what a cytokine was?
It's like a messenger cell.
Okay. Yep. It's a messenger that the white blood cell sends to the bone marrow to say, hey, I need more. I need more help. Okay. And then the bone marrow will in kind release more white blood cells. Okay. So this cytokine release syndrome, okay, this can happen from getting Simulect. All right. What's going to happen is that your body is going to overproduce cytokines. Okay. It's going to overproduce cytokines. So you're going to have way too many in the body. They're going to mass rush all of your bone marrow. And basically, you're going to have a mass dump of a bunch of white blood cells in your bloodstream. What that's going to do is cause an anaphylactic response. Okay. And you're basically going to go into anaphylaxis from like too much of an immune response, just like what would happen if you got, triggered with like an asthma attack or something, like that type of anaphylaxis. Okay. So you're going to see the, symptoms like that, like again, like possibly like angioedema, like decreased blood pressure, fast heart rate. Okay. Does this make sense? All right. And then I have to give you epinephrine to treat it. Okay. Are we good to move on to the next drugs? Okay. This one right here, cyclosporine or Sandamune, however you use Sandamune. All right. This one, the only thing I need you to know about this is the black box warning right here. Okay. So basically, it can cause, again, that nephrotoxicity. It can actually increase the risk of serious or fatal infections. Okay. So you could actually die from an infection that this one causes. It also causes liver failure. okay, which we saw with the generic ones. So if you wanted to cross these ones out because they literally go with the rest of what everyone does, that's fine. They can also cause seizures, inflammation in my brain, or skin cancer. Okay. So all I want you to know for this one is the black box warning. Okay. These ones right here, I'm literally going to refer to them by Capaxone and Glynia. So if you just want to know these names for these two, that's fine. Okay. These ones tend to treat MS. Okay. So all I want you to know is that they treat MS. Okay, which is also an autoimmune disease. Okay. And that this Glynia has these adverse effects here. The hepatotoxicity, again, you don't have to worry about because we know that like any immunosuppressant can cause that. However, it can cause cardiac issues like dysrhythmias, bradycardia, or hypertension. Okay. Questions here? And remember, that's only for Glynia. That's not for the Capaxone. All right.
The dysrhythmias and hypertension.
Yep. Okay. All right. And
Well, I
then
do got a
this,
question. I'm sorry. So
yeah,
you said the cardiac issues is just simply for the glynia.
you are correct.
So the Copaxone is whatever is listed under, and that's all.
Yep. I just basically put these together because they both treat the same thing, but then we're just talking about the adverse effects for one of them.
Oh, okay, cool. Thank you.
Yeah, no problem. Okay. Thank you for asking. All right, we got a few more, and then we'll be done with this chapter, and then the other chapter is really short. Okay. So we have this one, Cellcept or Myfortic. These ones are two different versions of this one right here, mycocephalinolate. I'm not gonna pretend like I know how to say that. But basically they're two different versions. They're not the same, but they're almost identical. So we kind of put them in the same category. So just know that Cellcept or Myfortic cannot be used interchangeably, but they're almost the same drug, which means like when they make them, there's like a few differences, but they basically act and do the same thing. Okay, so that's why they're in the same category here. You do not need to know this name. As long as you know the Cellcept and Myfortic, you should be fine. Okay. The black box warning here, all right, it can basically cause spontaneous abortions. So it can give you a miscarriage, okay, and it can cause damage to your fetus. If it doesn't kill it, it will severely damage it, okay? So not good for pregnancy, all right? And then the adverse effects that these two have would be fluctuations in blood pressure. That's why hypertension and hypo are listed, okay? Swelling, fast heart rate, high blood sugar, high cholesterol, and electrolyte issues. Okay. Any questions here for this one?
Yeah, so what do you want us to know? All of this?
I want you to know that Cellcept and Myfortic cannot be used interchangeably, but they're basically the same medication. And then I want you to know that it can cause miscarriages or fetal issues. And I just want you to know this list right here. Simple enough? Okay. Here, I just need you to know both of these names, but this is sirolimus. Okay. Basically, the only thing that I want you to know about this one is that it can also be used as an antifungal and an anti-tumor drug. Okay. That's all I need you to know about that one. All right. So just some other uses. It can kill fungal infections or it can be used for cancer. All right.
And are you
Otherwise,
going by both names for this one?
I'll probably more go by sirolimus.
Okay.
Okay. And then this one right here, you should know both names. All right. Tractolimus is one of the biggest immunosuppressant drugs that I see. And then make sure you just know this name too, because it is so popular. You probably should know both names. Okay. This one right here, if you are pregnant, you should not be handling the medications. That means like if you're a nurse and you're pregnant and you have a patient that's getting this medication, you probably shouldn't be handling it, or you should be wearing like 2 pairs of gloves, because any kind of, you can get like secondary exposure that could hurt your baby. Okay. I'm not saying that you can't handle it, but it would just be, you would need to use more caution. Okay. So like triple. Okay. It can also cause increased thirst, confusion, or heart failure. So heart failure right here is a huge adverse effect. Okay. Otherwise, that's it for this slide. Any questions, concerns? There's just a few things that I want you to know about each one. Okay. My nursing implications, as always, I just want you to read through these, but just to highlight a few of them. Okay. You should do a very thorough head to toe assessment before you give immunosuppressants, just to kind of have a baseline of what you're working with, since it can cause so many issues, adverse effects, and stuff like that. Okay. Because it's going to affect my white blood cell count, that needs to be monitored very frequently. Okay. We also need to monitor for infections, since we're dropping the white blood cell count, my patient's more at risk for getting them. Okay. So like checking their temperature, their vital signs, watching for fevers, all that kind of stuff. Okay. They should be getting, or they should be practicing infection prevention. Okay, so not going into large crowds, wearing a mask when they're out in public, avoiding anybody that's sick, frequent hand hygiene. Okay, frequent like disinfecting of their environments. Okay, not sharing any kind of like personal items. All right. Otherwise, if you're taking this for organ rejection or for graft versus host, it will be lifelong. Okay. The immunosuppressant. And then if you're taking it for an autoimmune disease, usually you will be taking it lifelong too, to keep the autoimmune disease under control, because the autoimmune disease isn't going to go away. All right. Otherwise, yeah, that was pretty much it. Questions, concerns?
So you said that the first information that we went over covered
Mm-hmm.
most of the slides.
Yes.
So is that like what we stick to? It's nothing like, because I came across the B cells. Did we go over that?
That was the antibodies.
Okay.
Yeah, so you don't have to get super specific.
Okay.
Okay. Just very surface level.
Okay.
Okay. So just what I showed you, let me show you again. Just what I showed you on this bad guy right here. All right, is what I want you to know. All right. Questions, concerns about that?
Yeah,
All
I
right.
could see most of it underlined too. So
Perfect. Yep. I did that for you too. I'm trying to help.
okay, thank you.
Yeah, I literally took those slides from Beginner Med Surg 1 lecture. Okay. All right. When we talked about immunity. Okay. I just bring it back up in my students' faces and be like, it's back. All right. Any other questions, concerns before we go to 49? Just want to make sure before I start a whole new thing. It's just basically more of this, so I'm not going into like a whole new topic, at least. So take a second, think about it.
We good. We can move on.
Okay. Let me share my screen for 49 then. Like I said, it's just basically more of the same exact thing, just a little bit different. So let me bring that up here. Okay. Everyone can see my screen. We're good? Okay. So basically here, we just talked about immunosuppressants. We kind of talked about the immune system and the basics of that. So now we're going to basically talk about vaccines. So this isn't going to be anything super crazy. Like I said, we kind of already introduced that. All right. But we already defined what an antibody was. That was made to help with my white blood cells to kill pathogens. Okay. Does anybody know what an antigen is? I used that word once before. Does anybody remember what that is? An antigen.
It suppresses the immune system.
Not quite. The antigen was, if I go back to my bad guy up here, all right, my antigen was the marker. Okay. That was, let me zoom back in. The antigen was my marker or my fingerprint on either my cells or the pathogen. So when we talk about a pathogen's antigen, it's basically their ID card or their fingerprint that tells me that they're foreign. Simple enough?
Yeah.
Okay.
So it's the marker or the fingerprint.
Correct. Or their ID card, however you want to think of it. Okay.
Okay.
Okay, perfect. I think hopefully that would help. All right, and then we went over adaptive and innate in the beginning. Does anybody have any questions about that, or are we good? Okay, just want to double check. All right, so I like this picture right here. It's a great way to summarize this. So have you guys heard of like active and passive immunity? Have that kind of like been brought up before?
Yeah.
Okay. So the best way to explain this is that active immunity is any antibodies that you are making, like my own body made it. Okay. And then passive immunity is any antibodies that I'm getting from someone else. I did not make them. Okay. So again, just to summarize, active immunity is any antibodies that my own body is making for myself. All right. Passive immunity is any antibodies that I am getting from another person. Okay. Does everybody understand that? Okay. So natural active immunity is going to be, I just get sick naturally and my body, like I got COVID from someone and my body makes antibodies to it. So it's happening natural in nature. There was no human manipulation. Okay. Artificial active immunity would be a vaccine. Okay. That means that someone is giving me a part of that pathogen, injecting it into me, and I am making an antibody to it. Okay. Did that happen naturally? Did I just happen to come across the pathogen in like everyday life? No, it was human manipulation, right? Someone like stabbed me and put it in me, right? Does that make sense? But in both cases, my own body is making the antibody from the exposure. Okay. Question, we go with this one. Okay. And then passive immunity. Okay. This again is me getting antibodies from someone else. So the natural way that this happens is in pregnancy. Okay. Babies get antibodies from their mother while they're in utero from the placenta or from breast milk. Okay. And then me getting it from someone else that's not natural through human manipulation, which would be the artificial, would be like we talked about those monoclonal antibodies. Like again, using the COVID example, like someone got COVID, they recovered from it, their body made antibodies naturally, and then they donated the antibodies and they gave them to me. Okay. Does this make sense?
Yes.
Okay. So make sure we're aware of that. Okay. All right. So biologics, all right, are basically anything that's used to prevent, treat, or cure an infectious disease. Okay. Usually the way that these are made, okay, is either in the form of a vaccine, okay, where I'm basically giving you, if it's a live vaccine, I'm giving you a weakened version of the pathogen. Or if it's an activated vaccine, I'm giving you a dead or a deactivated pathogen. Usually we give you the dead or deactivated one so that you don't get sick from it. Okay. Then I can give you toxins. Okay. Because if we don't, or if we're not aware, bacteria. So when I get sick from a bacteria infection, Bacteria can actually release toxins. They're kind of like just random chemicals that bacteria release when they're inside you. And sometimes those toxins can do more damage than the actual bacteria. Okay. So if it was one of those, like one of those bacterial infections going to be anthrax. If you'd have anthrax, those bacterial infections, they cause a lot of damage because you have damage from the bacteria and damage from the toxins that they produce. So you're basically going to need to be given an antibiotic and then an antitoxin. Okay. So if we give you an antitoxin, that would be an example of a biologic. Does this make sense? Okay. I can give you someone's antibodies, which we talked about with the monoclonal antibodies. Or what's a titer? Has anybody gotten a titer drawn from a blood draw?
And it's a lot to see how much of it is in your system.
Yeah. So basically, I'm getting a blood draw to show what I have antibodies to, what I'm immune to. Okay. Okay. Any questions about this slide before I move on to the next one? Okay. So there's two types of these. There's active and then there's passive. Okay. So if I'm giving you a biologic, usually to prevent or treat an infection, it's going to be active or it's going to be passive. These are not antibiotics to treat infections. So I want to make that clear. That's a whole separate category of treatment. These are more immune system based. Okay. Does that make sense? These deal more with antibodies than antibiotics, which deal more with killing the bacteria. Okay. Are we good there? Okay. I just want to make that distinction. We are not talking about antibiotics, but we're still talking about treating infections, just in a different way. So active is usually used to prevent an infection. Okay. Those are going to be my vaccines. Okay. Then passive is usually going to be my antitoxin or my anti-venom. Okay. Usually this is going to look, an antitoxin or an anti-venom is going to look more like a monoclonal antibody. Okay. Because like if you get rabies, we don't really vaccinate you against rabies. But if you get bit by a wild animal and they have rabies, they're basically going to take you to the hospital and they're going to give you an antitoxin. Okay. Those are antibodies that they're going to give you to fight the infection. Okay. That was either lab made or made from a human.
So, for an example, when you get bit by a spider, by a snake, you
Mm-hmm.
need, don't they
Anti-
like take the venom of the spider, of the snake and like make a passive drug?
so what they usually do is they usually will actually have the venom there. Like they'll draw it from the snake and then they'll inject it into another animal. It's kind of cruel, like a horse, and the horse may die. However, or the horse may live, but before the horse dies or when the horse lives, they're going to produce antibodies to the venom, and that's what they're going to take and inject into you.
And the horse antibodies, like that would translate into human immunity?
The lab may double check it just to make sure it would. They may have to alter it slightly, but basically, yeah, you're going to get almost pure horse antibodies. Yep.
So, I
So
got a question. So, if I get bit by a snake and they can't find that snake, you'll die?
yeah, you need to know what snake it was. So because every snake has its own venom. So
That's why he did that.
yeah. So basically, every snake would have its own venom. So you would need to know what kind of snake it was, so that when you went to the hospital, hopefully they would give you the right anti-venom.
Got it.
Okay. Any questions here? So you can see how that's me giving you antibodies from someone else, right? So that would be the passive. Okay.
Do you want us to know like all the active and all the passive?
As long as
Um,
you more know that this is vaccine and this is more anti-venom, antitoxin, I think we're good. And that you're getting
okay.
antibodies. Okay. Okay.
All right, thank you.
All right. Just really quick because we have to talk about it. Immunizations, vaccines, are they safe?
No, no, they
So
can kill you.
they can't kill you. But this, not to start a debate because we don't have time for that. However, this is a huge debate, right? I'm not telling you one way or the other. Of course, NCLEX and medical world are going to say always vaccines are safe. Vaccines should be given. But I'm not here to tell you my opinion. I'm just basically telling you that there is a debate whether they're safe or not, because we know that there are links to not just autism, but autoimmune diseases and other types of like immune responses and things like that to vaccines. Okay. Whether it's proven or not, I don't know. Remember when we talked about correlation doesn't mean causation? Just because we see it trending that way doesn't necessarily mean that one is causing the other. So that's why the debate is kind of there because there's evidence on both sides. So it's just kind of, we don't have it confirmed. There's enough evidence on both sides that we're not, just depends on what research you look at and what you want to go with. But again, many parents may be reluctant to vaccinate their children or get vaccines themselves. So just know that that is a issue. We good here? But the one study that was done that did show that autism was caused by vaccines, I think it was done in England. It was fraudulent. He already picked volunteers that had autism. So that was proven untrue. However, there are, like I said, new studies that are shown on both sides. Okay. So just know that one of the concerns was a preservative called thimerosal, and that they have no longer, they're no longer putting that in most vaccines. It can be in some vaccines, but usually in a lot of them, it has been removed. Okay. We good here? Okay. So why are people taking these? Again, the active kind, we're taking it either to immunize ourselves or to get herd immunity. Are we all familiar with what herd immunity is, or do I need to go over that?
Go over it.
Okay. It was kind of like when COVID was rampant. They said everybody should get a COVID vaccine so that even if you weren't at risk, you would be protecting someone that was at risk. So basically, like immunosuppressant populations, they are more at risk for getting diseases. So they can't really get a lot of vaccines. So you would be protecting yourself by getting the vaccination, but by you getting the immunity and you having a less likelihood of getting the disease, you have a less likelihood of spreading it to the person that is immunosuppressant. Does that make sense? So basically, like if we build up someone's community with immunity, there's going to be less people that will be sick to give it to that person that's vulnerable. Okay. So we can see how vaccines would fit that theory. Does that make sense? Okay. And then passive immunity, we talked about that. That's kind of just, again, antitoxins or antivenoms. Okay. Or it can be monoclonal antibodies. Okay. How these work, they stimulate your antibodies, which are a form of adaptive immunity. Simple enough. Okay. Contraindications. If you're allergic to a vaccine, should you get it? Probably not. They do have different versions, so you would probably have to find a version that didn't have ingredients that you were allergic to, or you may just not be able to get that vaccine. Okay. Um, if you have a fatal illness like rabies and you're allergic to the rabies antitoxin. Should I still give you the rabies antitoxin, or should I let you die from rabies?
Yeah, still give it.
You still give it because I can more easily treat the allergic reaction. There's only one treatment for rabies. Okay, so just keep that in mind. And if you have a current infection, you should not get a vaccine. Okay, you should wait till you're not sick anymore and then get that vaccine. Okay. All right. Interactions aren't common. Usually, vaccines will interact with other, medications that you're taking. However, if you are immunosuppressed, so you're taking steroids, chemotherapy, or immunosuppressants, anything that's going to lower your immune system, the vaccine may not work as well, or the antitoxin may not work as well. Okay. Because the goal of that is to create an immune response, right? When I give you a vaccine, I'm hoping to create antibodies, right? If my immune system's lowered, I can't make those antibodies. Simple enough. Yes, no. Okay.
Yeah.
Okay. I'm not saying it won't work, it just won't be as effective. Okay. All right. My adverse effects here are I can get swollen lymph nodes, rash, fever, sore throat, injection site pain or redness. Okay. I could get neurological side effects like confusion, hallucinations, seizures, encephalopathy, weakness, loss of sensation. So lots of, like I said, difficulty breathing, peripheral neuropathy. So these would be some of the more serious adverse effects. They're supposed to be rare, but again, we do see them. Okay. Probably the first one is going to be more of the ones that you see: injection site redness, soreness, swollen lymph nodes. Okay. And those should be temporary. Okay. And then you get serum sickness. So basically, what this is doing when you get a vaccine or a passive like monoclonal antibody or something like that, sometimes it can overstimulate your immune system and you kind of can go anaphylactic. Okay, so it's kind of similar to that cytokine release syndrome. Here, you're overstimulating your immune system, and then you can get anaphylactic. So I have to give you antihistamines, epinephrine, that type of thing. Okay. Questions there? Okay. I'm just giving you examples here. Again, active is mostly vaccines. Okay. Whereas passive is more antibodies or like monoclonal antibodies, antitoxins, or antivenoms. Okay. Otherwise, again, just know your immunization status, know if you're immunosuppressant. Manufacturing drugs need to be stored correctly. Usually they need to be refrigerated. You got to check vaccine schedules and just things like that. Okay. Does anybody have any questions or concerns?
Can I ask a question about there's like the list of active vaccines.
Yep.
For the herpes zoster vaccine, that's like the shingles vaccine, right?
Yes.
Is there a reason that they only give that to people that are like over 55?
So it's the same, almost the same vaccine as the chickenpox vaccine, because it's the same virus that hurts you. They just specialize it for more dormant days, because you usually get shingles later in life.
Well, what if you've had shingles like young? They still won't give you the shingles vaccine. Like they still want you to wait till like 55.
That
I've always wondered why.
I'm not sure about that one. I'd have to
Okay,
look
that's
that up.
it.
Yeah. Okay. All right. Anybody have any other questions? Okay. Like I said, I'm recording this. I will try to upload it tomorrow if it is ready. And that is it.
Thank you.
Shingles
Yep.
again. Thank you.
Thank you. Please do your remediations for your farm, Hesse. Okay. All right. I am ending the recording.